We're going to have part 3 coming up here in about a month. I know last time we had everybody join and we had the registration link ready to go for part 2. I will be sending that registration link out within the next few days. We were just talking before the webinar started about how fast time is going, and I think everybody's going to agree with us. We just run out of time, so we're going to get that next registration link to you very quickly. But thank you for joining again. And a couple things before we get started. My name is Emily, and I'll be the host today. But more importantly, we have Dr. Lon McRae with us today. Dr. McRae, thank you so much for joining. And this is your second time, and we're going to keep tying you into these webinars, but we're grateful to have you. Thanks.
Oh, you bet. I love being here.
Awesome. And then we also have Marius Van Tonder with us. Marius, thank you so much. We're grateful for you as well. You bring the lab technician side kind of perspective to this situation. And I think that that's what's kind of missing in dentistry today. Kind of the connection or the marriage, maybe marriage is the wrong word, but between the dentist and the lab technician, and just really open communication about what's needed in order to make great things happen. So Marius, thanks for joining.
Thank you very much.
Perfect. Okay, so I've done this several times. I've read the bios out loud and it just takes forever. And I'm a terrible reader when it comes to presenting. So what I'm gonna do, we wanna listen to these guys more than anything. I'm gonna put their bios in the chat. So if you'd like to learn more about both of them, you'll go ahead and just click on the little chat box on the control panel on the right-hand side of your screen, and you'll be able to read about them, kind of their history, how they got to where they are and where they're going, I guess. Also wanted to remind everybody that, as always, we are recording this webinar. Anyone who attended or even registered will receive this webinar within the next few business days. And also wanted to remind everybody, we are going to do a Q&A session at the very end of the webinar. So as your questions come up, just type them in the chat box on the control panel on the right-hand side of your screen, or the question box. So chat or question, they'll come to me. The questions will. And since you don't have audio on your end, I will read the questions out loud, and then we'll get some answers for everybody. Now, again, just want to remind everybody, we will be presenting a part 3 to this webinar series. Shortly, that registration link will go out, and I'll remind you at the end of the webinar. We look forward to seeing you on that third part 3, basically. And that being said, I'm going to go ahead, and today we're going to have a little bit more focus on Marius's perspective. If you joined into the first session, it was a lot about what Dr. McRae does. Marius is going to go ahead and share his screen. Dr. McRae and I'm going to stop sharing my screen, or not my screen, my camera. You're welcome to leave yours on or turn it off, whatever you'd like. And we'll turn the time over to Marius and let you get started from here. Marius, we'll let you jump into it.
Allow me before I start my presentation, Dr. McRae spoke last week about we always talk about the team, the importance of the team, right?
I think it was last month, but just so you're not
sorry, last month.
It feels like last week.
It does. That's how quickly time flies, right? But who is that team? We know about the doctor, right? Or the surgeon. We know about the implant planner, and then we know about the lab technician. Now, who else is there? And this is what I want to talk, or that is the person that I want to talk about today. I think these people are very often not appreciated enough. I think, Dr. McRae, you have an idea what I'm talking about, or who I'm talking about?
Absolutely. In fact, a lot of us call them dental assistants, but I've changed the name, and I don't call them dental assistants anymore. I call them surgical assistants, because that's really who they are. And we were just talking briefly just a little bit ago, and it came to me, about 90% of everything we do, my surgical assistants take care of. And think about this: as soon as the patient accept treatment, so the treatment plan is done, yes, by me. I go through that usually with the hygienist, sometimes with them. But then they're taking the CBCT, they're taking the scans, they're taking the photos, they're taking the intraoperative photos. They get all the information to the financial team. The financial team then takes it from there. On the finance side of it, once the finance side is done, then it goes to the design team. That's Marius and his team. Then they set up the meetings. with Marius, which is the Zoom call. We get on the Zoom call and we're going to go through all of this. But I was just thinking in my mind, the easiest part is what we do by far. It's the enjoyable part. They take care of all of the stuff that we get to then be able to be the hero, come in and be able to do this work. We can't do this without them. And again, I think this was more along the lines of the medical model of how things should be done surgically. The doctor, the day of the doctor doing everything himself, I think that that's not a team approach, and I don't think you're going to be as successful.
I fully agree.
I'm just going to chime in here from my perspective. I've been in the dental industry for a very long time, and I generally trained assistants how to do intraoral scanning. And it was a funny thing. When you trained an assistant, you knew they could see right through you if you didn't know exactly what you were doing. And they have so much experience that they bring into the clinics a lot of times that is sometimes discounted. And I love the fact that almost in word, you've given them a bit of a promotion. Surgical assistants is what they're doing for you, because they bring a lot of knowledge base to the table, and it's often kind of overlooked, and their capacity is quite high. They're able to do a lot if they're just trained a little bit deeper in what's needed. So I love that.
Absolutely, and they are really the foundation. They are the start of the whole process. They're the foundation, and this is what we're going to talk about today. I think many of you may consider this as, yeah, I know that, but you know what? I realize every day that no, not everybody does know this. So allow me to explain what it is we need when we want to do these all-in cases. What do you need to send to us? And what are they supposed to look like? So I'm going to share my screen.
Perfect. I will go ahead and turn my camera off now. We'll come back once we get those Q&A questions going. Perfect. Yep, looks good. We've got your presentation up and we can still see you. So we're good to go.
Okay, so you can see it in full screen mode, right?
Yep. Okay,
so today we're going to look at what we need from the clinic. And again, who are the people who generate this for us? It's the dental assistants. And you know, we are as good as the scans we work on. And that goes all the way through planning, through designing, all the way to the surgery. So it's very important for us to go to the very beginning. Where does everything start? And let's look at what we need to be able to do these cases. And well, I was surprised. We need a CBCT. You knew that, right? But boy, is this something that we struggle with on a daily basis, is really the quality of the CBCT. There's a couple of things that go wrong, so allow me to share those with you. The first thing we need, it needs to be out of occlusion. So the patient's going to bite on that little mouthpiece in the CBCT, and so it has to be out of occlusion, but we're going to look at that in a bit. We need a full scan. Now, when I say a full scan, I need to be able to see the entire mandible, and in the maxilla, I need to go at least to, I would say, even half of the sinus, because we want to see the sinus floor. I very often get CBCTs in the anterior where it's just cut just below the nasal cavity, and then it's difficult for us to know what implant we can place there. Could we potentially go longer, or do we need to keep shorter? So it's very important that it has to be a full scan. No movement. I know this is a tall order for some people. Some people have tremors. Some people find it difficult, like myself, to hold still, but movement causes a lot of problems, and we're going to look at that in a second. And then the fourth thing is we want as little scatter as possible. Now, look, scatter is part of a CBCT. It's just how it is. Zirconia, restorations, even root canal treatments, implants, metal dentures, metal inlays, onlays, all that causes scatter. And it's very difficult for us sometimes to work on some of these CBCT. So let's take a look at some of this. I was talking about the scan being open, right, out of occlusion. Why is that important? Well, for two reasons. The first thing that I want to do is I want to be able to segment the maxilla and the mandible. I want to be able to separate them so that it's not one bone volume, but a maxilla and the mandible. And I can choose which one I want to work with. So if I'm planning this case in the maxilla, this is what I'm going to be working on. And it's always nice to be able to see the occlusal view of the maxilla or the mandible. If I want to work in the mandible, then that's what I'm going to do. The second thing that's very important, why these should be open out of occlusion, is we need to merge the STL file to the CBCT. And I do find some people do not understand exactly why we do this. So I'm sorry for insulting you if you do know, but just allow me. We do all the planning in the CBCT, right? So that's where the bone is, that's where the teeth are. So we do the planning there, but when it comes to designing the surgical guide, we're going to do that on the STL file. So if the STL file and the CBCT is not 100% accurately merged, we are not going to be placing that implant where we want that implant placed. And many times we get scans where we just cannot get it merged. So it's very important. For that reason, if it's open, I can very easily access the buccal surfaces, but also the lingual surfaces or the palatal surfaces, the whole occlusal surface of all the teeth. And for that reason, it's easy to find corresponding points. If this patient was in occlusion, there is virtually no way for us to be able, okay, so this patient did not have that many remaining teeth, but we need to be able to see the buccal cusps, at least the buccal cusps of the mandible. Now, because of the overbite of the patient, it's impossible for us to see the buccal cusps because they are now hidden behind the maxillary buccal cusps because of centric occlusion. So then sometimes we're lucky and we can turn the scan around and we can go find the lingual cusps from the lingual surface. We can access them there, but that's not always easy, and we do struggle with the alignment in those cases. So please make sure that CBCTs are open. Here's an example of what we have received. Apart from the fact that it looks like a major explosion, these are CBCTs that we get. And this is not a beginner doctor. This is just, we spoke about this a while ago. The doctor does not even see the CBCT by the time it comes to me. The assistant takes the CBCT, uploads it to our portal, and whenever we get a case like this, obviously we cannot work on it. I cannot find corresponding points between this and the STL file. And we do see, amazingly enough, we do see, I would say, too many of these. This is a very common problem, and this is all because of movement. So you can see the right and the left look pretty decent, but then right here in the middle where the two join, it does not align properly. All this means is that this patient moved the mandible during the scanning process. And all this is going to result in is we will not be able to align the left and the right-hand side of the STL to the left and the right-hand side of the CBCT, because the one is now in a wrong location. Which one is wrong? That's typically a good question. We don't know, and for that reason, a case like this we can unfortunately not use for planning. That seeing, or when we look at that specific case, you can see the canine, the lateral, the center, the central. This is the one arch meeting that arch, and you can see that misalignment. So it's not This is not microns. This is multiple millimeters. So I can guarantee you that the distance between the second bicuspid and the second bicuspid in reality is going to be bigger than it is in this, because these two CBCTs have been, or the two quadrants have basically been squashed into each other. We were talking about scatter. Scatter is a problem because we cannot see corresponding points. I cannot see the cusp tips, and it's very difficult for us to do the alignment. And let us never forget that, you know, at the end of all of this is the patient. The patient is the one who pays all our salaries, whether you're the doctor, whether you're the implant rep, whether you're the technician, whether you're the implant planner. It's all about the patient. Now, am I going to take a chance on the alignment? Let's give it a go. Let's try our best. That's not good enough. I can unfortunately not work on a CBCT like this. And then people ask me, but okay, but what am I doing wrong? And you know what, I so wish, and I do believe in the future we're going to get someone from a CBCT company to answer some of these questions, because I just don't know what you can do in the CBCT to solve these problems. But what I absolutely do know is we cannot do implant planning on a CBCT like this. So that takes care of the CBCTs. Let's look at the STL files, upper and lower. Intraoral scans. Nowadays, I think there are still doctors. I don't work with any of them. There are still doctors out there that do not have intraoral scanners. They are doctors who take analog impressions. They send it to the lab, and maybe the lab will cast the model and scan the model. I'm fortunate that all the doctors that I work with take intraoral scans. It just makes life so much easier, and I can really recommend you to get one if you don't have one yet, because you know, there is not any questions anymore about the accuracy of these scans. So yes, they are absolutely accurate. But let's look at what we need on the STL files. We need them to be in occlusion, and I will talk about that in a bit. We also need full arch scans. Please do not send me a quadrant scan, because it is impossible for me to align a quadrant accurately to a CBCT. Our software won't even allow us to import a, we can import it, but it will not accept the alignment of a quadrant scan. So please, the scans have to be full scans. We want no saliva. For the same reason as you do not want saliva when you do a crown preparation or an inlay onlay veneer. Saliva always is a problem, and I will show you an example of that. And then we want as much gingiva as possible. Now, Emily was talking about the days when she was training assistants in using intraoral scanners. I can remember I was involved with that for a while too, and we always would say just scan about 2 or 3 or 4 or 5 millimeters beyond the gingival margin. That's good enough. Yes, absolutely, that's good enough if you want to do a crown, a bridge, inlay onlay, because you know, you're not really working with the gingiva. We want as much gingiva scanned as possible. In many cases, not for all in, but for just implant planning cases, where we have distal free end extensions, like in this mandibular case, we want to place anchor pins. Now, typically, we need to place those anchor pins quite high up or quite low down, so we need to know where the gingiva is. And then another reason is when we do with implant planning, with all-in cases, we often use the gingiva also as part of alignment. We can see where the gingiva is in relation to the tooth. If we want to do partial extraction therapy, we know where the gingival margin is, where the root is in relation to that. So we absolutely need as much gingiva scanned as possible. This is a big problem. And allow me to, I would take a guesstimate that 60% of scans that we get are not in proper occlusion, if not more. Now, intraoral scanners nowadays allow you to scan the left and the right. So when you need to do the bite scan or the buccal scan, as we call it, you need to do it on the left-hand side and you need to do it on the right-hand side. Now, why is this a problem? I can absolutely see on the wave facets on the canine, and there's a little wave facet on the bicuspid. I know this is not centric occlusion. Now, I need to design a restoration, a temporary restoration, and we want that restoration to be at least 1.5 millimeter, 1.5 to even 2 millimeters out of occlusion. Because remember, we're loading this implant immediately, and in no way do we want that temporary restoration to be in contact with the opposing. Now, if I do not know where centric occlusion is exactly, I may sometimes design the restoration thinking I'm 1.5 millimeters out of occlusion on this case, but the occlusion is open by, let's say, 0.5 millimeter or even 1 millimeter. That means instead of a 1.5 millimeter spacer, I now have only 0.5 millimeter spacer, which is not adequate. So it's very important to do the buccal scan on the left and the right. And this is something that the assistant can check. I know it's very difficult on a CBCT to check if the CBCT is good before we go, but you generate these files and you can see immediately when a bite is wrong. You can check the bite and you can rescan. So please make sure that these bites are correct so that we can make sure that those restorations are well out of occlusion. Then, yeah, let me also mention, let me go back. This also applies when we do a normal, just normal implant pain cases. We also need these cases in centric occlusion. Saliva. Saliva is a problem because saliva, the way an intraoral scanner captures saliva, it does not capture it as a positive. It captures it as a negative. So allow me to call it a bubble of saliva was sitting there. The software does not read the outside of the bubble, it reads the inside. So what you find is it creates these holes in the model. And this is a problem. Because remember, what do we do with the all-in workflow? We need to be able to trace the junction between the tooth and the gingiva. And you can see in this STL file, it's perfectly clear. Now, if I go back to the previous slide, I do not know where this tooth contour is, so I'm pretty lost. You can see where the white line was drawn or where it was segmented. This is not accurate and this is not good. Now, what happens is we are going to have a problem with the contacts, the interproximal contacts. We're going to have a custom healing abutment, not properly sealing the socket, or the opposite. We might have a custom healing abutment that is just squeezing the life out of the gingiva because we did not, or we were not able to trace that accurately. So that's what saliva does. But we need to be able to trace that line perfectly, because then we can do the segmentation of the root and we can do the extraction of the root. And we know that everything is accurate, everything is good, and the custom healing abutment that we design is actually exactly where the contours are. So that, in a nutshell, is really what we need file-wise from the clinic. So I would really encourage you to help the assistants to be able to do better scans. You know, I've seen CBCT companies, intraoral scanner companies, very eager to sell you a product, not all that eager to give proper training. These poor people do not know how to use these devices properly if they are not properly trained. So, you know, invest time, because at the end of the day, when that assistant gives us good files, you're going to have a good surgery. If we get bad files and we were to accept it, which we won't, but let's say, that implant is not going to be where we planned it. And the accuracy level that we work with the All-In system, it's next level. So we need to make sure that these files are good. Another thing that I find is a bit difficult for some to understand is we talk about the All-In workflow. Now you want to submit a case to us, and we have a couple of options. So the first option is an All-In complete. When we say All-In, one thing always has to be the root, the tooth, the whole clinical tooth, or just the root has to be present. The extraction of the root or the tooth is part of the workflow of All-In. So always remember, when it's All-In, it cannot be a healed site. It can only be on a tooth that is still present. Now, when we talk about an All-In complete, we are going to send you the surgical guide and the surgical report. We are going to send you the custom healing abutment. We're going to send you the custom abutment and the temporary crown, or if you want, it's going to be a one piece, and we're going to send you the printed models. And then an All-In 2 stage, again, it's an All-In, so the tooth is still present. But in this case, we are not going to load it. We are just going to use a custom healing abutment. So in that case, we're going to send you the surgical guide, the surgical report, the custom healing abutment, and the printed models. And then the third option is immediate load. And this is very confusing for us sometimes. A doctor sends us a case, it's a healed site, let's say at number 12, and then the doctor asks for an All-In on number 12. And then it's like, yes, something wrong. It cannot be an All-In because number 12 is still there. That they maybe choose the wrong tooth. Should it be number 11 or should it maybe be number 13? An immediate load case is in a healed site. That's the difference between an All-In case and an immediate load case. In that case, we're going to send you the surgical guide and the surgical report. And then if, you know, depending on whether it's going to be a custom healing abutment, but we typically do a custom abutment and a temporary or a screw retained crown. So please make sure that when you select the product that you choose the correct one. All-In, the tooth is still present. Normal immediate load, that is on a healed site. And then the very last thing that we need is we need clear instructions. We need to understand exactly what you do. Now, when you submit the case on our portal, there's a notes section. And please, in that note section, please explain to us exactly what you want to do. We want to understand exactly what we're working towards. In this case was in the pre-op, you will see that the patient has a central diastema of about 1 millimeter due to rotation of number 7. We aim to close the diastema. Please correct the rotation of number 7, which will allow for the mesial movement of number 8. I wish to splint the 2 temporaries during integration phase. We have no doubt what this doctor wants to do, what the outcome of this All-In case is going to be. Number 7 and number 8 needs to be extracted. We need to rotate, so we need to realign number 7, which will allow us to close the diastema between number 8 and number 9. So please give us as much information as possible. And that is really the end of my presentation. I wanted to show you something. We had a meeting with Dr. McRae earlier, and we are going to look at this case in a second. But I just want to show you the people. Whenever I meet with Dr. McRae, those are all the people present in the meeting. So apart from him and myself, we have Michael Bradley on the right-hand side. He's implant planner at the new planning center. And then we have Sarah and Kenzie. These are Dr. McRae's two assistants. They attend each and every approval meeting. They know exactly, because they've been communicating with the patient. Many times I need to ask Dr. McRae, are we going to do an all-in complete, or is this going to be an all-in two-stage? And I can give an example. Dr. McRae will say, no, we're going to go for an all-in complete. Then one of the assistants will say, no, this patient agreed to an all-in two-stage. So I think it's crucial that we should start involving them in the process. They are also the ones who are taking the CBCTs and the STL files. So if we see something wrong, it's easy to communicate with them. And I think it's important for them to feel part of the team, so that we can, apart from the fact that we show them appreciation, I think it's important for them to share in the successes that we have. As Dr. McRae explained earlier, what they do, you know, in the clinic. It's not just like in the old days, the assistant would load the impression material in the impression tray and pass it to the doctor. The rest is going to be suction. That's the way I remember dental assistants. Oh boy, things have changed a lot. So that is really a wrap up for me. Dr. McRae, do you want to add anything?
You're exactly right. I mean, I think of what the surgical assistants do from the beginning to the end. They know the cases better than I do. When we go through the planning, it's so important as we go through the planning and we talk about how this is done. Even in the little changes, they're invested. They know exactly the process. They know the fears of the patient better than I do. And so they bring that to the meetings, and so we've been utilizing them for what, probably the last year, roughly, maybe, and it's gotten so much better. And the questions and the confusion, it all boils down to, and Marius, I'm sure you agree with this, all of this is about communication.
Yes, absolutely.
And it's understanding each other's, dealing with the design team, with you. Yeah, it's all about communication with and what the patient's ultimate desires are. So yeah, it's very good, Marius. I think this is very helpful.
I do like the word you just used, confusion, because that's what it is about to me. We eliminate any confusion. Nobody is going to do work that nobody asked them to do. We're not going to give this patient a all-in complete, but the patient only agreed to a custom healing abutment or all-in two-stage. So I agree. Communication, and it eliminates any confusion, any surprises. I want to just do one more thing. So we did this case earlier, and I messed it up a bit. I just want to show you guys what Dr. McRae and I do when we look at an all-in case. So allow me, this is going to be quick. We typically do these meetings in a very short period of time. So let me just give me a second. Let me just pull up. You can see that screen?
Yes.
With the implant planning?
Yes.
Okay, so this is typically where we start. I do not know. Are you guys seeing this flickering?
Yeah.
Or not?
Yes.
Okay, yeah, that's unfortunate, but let me just see if. No, I don't know why that flickering is so bad. Let me try again.
Okay, we don't see any flickering now. It's just the windows.
Yeah.
Oh, okay.
I think we're good here.
Okay, great. So in this case, just quickly, tooth number 19 has to be extracted. So we do everything, and then typically by the time we're good for approval, we will look at the case. And then, Dr. McRae, I moved this implant.
Sure.
Let me, let me just find my, for some reason, my screen is just going absolutely crazy. So let me just try again. You can see the screen?
Yes.
Okay, sorry
I think
about
we're
that.
seeing the flickering that you're seeing.
Okay, great.
It might be bothering you, but it looks pretty steady to us, as far as I can tell.
Okay.
Yeah, I don't see any flicker on the screen.
Okay, great. So in a case like this, we can clearly see in the bottom center image, there's the outline of the root. So that part is going to be missing. And we have our buccolingual view. We have our nerve canal traced. So in a case like this, Dr. McRae, what would you like to you like to change? The implant that is in there at the moment is a Urus omnitapered from true abutment, 5 by 10 millimeter. So I just placed it randomly so that you can give me instructions where you would want to see this implant.
Okay, so what's nice is that, and I like how you're doing this, Marius. But what's nice is when you work with Marius and his team, they're gonna know where you like to place the implants the majority of the time, and so it's going to be usually he's going to place it in a place that I like to see it, which is going to be in that mesial root. And the reason we want in the mesial root on a lower molar is that you get a better angle through the center of the tooth, and because of the curve of spee that is in that lower jaw. And so if you see now, all of a sudden, before it was that angle was way off. Now it's going directly right through the middle of that restoration. That screw is going to be able to be screw retained. It's going to be much better. So what we're going to look at is I want to know what the distance is between the implant and the nerve. Can you give me a measurement on that, Marius?
Okay, let's take a measurement from the implant to the nerve canal. At the moment is 2.19 millimeters.
Okay, and so that's exactly where I want it to be. Is I want it to be a little more than 2 millimeters. I want to make sure that we're also, how far are we away from the adjacent tooth?
Let's do a measurement there for you.
A little bit close to that adjacent tooth, but let's see where we're at. We want to be roughly about 1.5 millimeters.
About 1.5, so let's mark 1.5 and then we can just move the implant to there. So that's about 1.5 millimeters away from the root of number 20.
Our angulation still looks good. Now can you show me the image I like to see to show me how much stability we're going to have in with the root and the implant?
Okay, now just give me a second because I had to move that window out the way. So you can still see my screen, right?
Yes.
Okay, so the view that you enjoyed, the flickering has now also stopped. This is the view that you typically want to see.
So this is what I want to see. I want to see where that implant is in relationship to the bone and see how much stability that we're going to be able to get. And so knowing that that whole mesial wall is going to be there, I'm going to take my extra careful to be able to make sure that I don't disrupt that mesial wall. And this is exactly what I'm looking for. And we should get pretty good stability with that. And so and then what I'm going to tell them is we want a CHA. We call it a CHA, which is a custom healing abutment. And that's what I want to finish this case with.
Okay, and then it's also important, right, when we see this view, the value of the septal bone. So if this extraction is not done automatically, and let's say a whole chunk of that septal bone comes out with it, we are going to lose quite a bit of primary stability because we are depending on that septal bone for that.
Or the other thing, Marius, and this is important, if you design this to put that directly in the septal bone, you're going to destroy all your stability. It's all gone. It's not going to be there. So you got to look at these and be able to decide. And we have found that if you place it in that mesial root, you get the very best result.
Absolutely. And then allow me to also mention that we also want as close as possible. You know, we can settle for 4, we can settle for 5, but I believe where we are at the moment, another distance that's very important for us to maintain. Let me just change the opacity of the yellow model so that, and let's switch off the tooth so that we can see the zenith and we can see where the implant is. Now that distance, because some of you may think, wow, but you're placing this implant very deep. Sometimes we place implants even deeper than this because it's very important for us to have a distance in the top left-hand side from the zenith to the top of the implant of around 5 millimeters. Now we're not always that lucky. Sometimes we need to go down to 4 millimeters because that's the best we can do, but it's very difficult for us if we have less than 4 millimeters. Remember, on top of that implant, we are going to place a tie base, and we want to create that emergence, that S curve. We need to be able to maintain that. So from the implant, we cannot go, 90-degree out. We need to leave adequate room for the bone and the gingiva below the restoration, if I can call it that, on the sides of the tie base. So that's also a very important measurement for us. Now, typically, by the time we do the preparation, and you can see in the bottom right-hand side, there's 4 millimeters. So we know we have room to move this implant. If Dr. McRae says, I want to move it up a bit, I know I can move it to that level because I know I am now 4 millimeters away. But if he says I want to go deeper, the measurement that's going to dictate, because this is a mandibular case, we never go closer than 2 millimeters. So that is the 2 millimeter mark, and then we know that we will have about 5.2 millimeters to the zenith. And that's really all we need to look at in these cases. So thank you, Dr. McRae, for that.
Yeah, and that's a great point. If you go too shallow, which I see this in all the teaching that I do, everybody wants to go 1 millimeter underneath the bone. Which bone? What bone are you talking about? Is it the buccal, the lingual, the mesial, the distal? Well, we're always talking about the buccal. So since we've been doing the zenith rule, it is by far the best way to be able to look at these cases. And then the other thing is if you're too flat, that's when you get that mushroom effect, and patients will always be complaining about food getting caught underneath their implants. So just as a rule of thumb, go deeper. If you go deeper, you're going to end up with a much better emergence profile, and the patients are going to be much happier, and you're going to actually save more bone than destroy.
Yes, and if I can add one more thing to what you just mentioned. So remember, we use the existing roots contour. So we know where the implant top is, and we now, from the implant, we need to get out there. That is the width. We're not making up the width. We are guided by the existing tooth that is there. So we need to get from the narrow implant to the wide portion of the implant. And that applies from in this view too. I need to get all the way there, and I need to go all the way there. So we need to have vertical room to be able to get our margin. If we had to do an abutment and a crown separately in this case, I need to get that abutment margin at least 1 millimeter subgingival. So when you consider I've got 4.63 millimeters, by the time I have taken, let's say, 1 millimeter more or less for the margin, there's about 3.5 millimeters left for me to get from the tie base platform that screws into the implant out to get in contact with the gingiva. So that is the important part of that. So I'm going to stop sharing my screen. I think we have taken care of pretty much everything. I think the bottom line of today is, if I can summarize, make sure we get the good scans we need, so that we can do good planning, so that the surgery can go well. Who are the people in general? Who are the people responsible for these? The assistants. And we acknowledge the importance of the assistants in this whole workflow. They are, I'm sorry, Dr. McRae, they are as big a part of this team as the surgeon is, as the planner is, as the technician is. We all, because what we do influences what happens at the end, at the surgery. So we are all a team of people with one common goal, and that is to give this patient the very best.
Good. Yeah, very
Excellent.
well said.
I like it. Okay, let me go ahead, and I am going to share my camera really quick here. You can see with the time change, it's gotten dark really fast. It creeps up on us at this time of year. Okay, a lot of questions did come through, and I kind of want to reiterate right now that this is part 2 of a 3-part series, and there'll be many more to come. But for those of you who want to learn a little bit more about the all-in process, maybe a little bit about or a lot more about from the dentist perspective what's happening, I would say go back and watch part 1. I think that's going to give you an idea of what kind of Marius is diving into right now. This is kind of, previously it was more about the what, like what is it, what do we do, how does this look, and right now it's kind of about how. And I think a big part of a planner's perspective, you know, Marius talked about him, and Michael, one of the other planners, is what you guys need. You know, how this is done and how to accomplish the what, like for the patient. So I would say go back and watch part 1, reach out to me, reach out to Marius. We'll give our email addresses at the end, reach out to Dr. McRae. We typically like to have a slide pop up at the end that has all of our contact information. I don't think we have that right now, but you can also respond to the email that you received this registration link through, and we'll get back in touch with you as well with that. So that being said, we do have quite a few questions that came through. I think some of them are going to be quick answers. Some of them might be a little bit more in depth. I don't like to keep people over time too much, but I also want to make sure that we get everybody's questions answered. So I'll just read them off to you guys. You guys kind of bounce them off each other, decide who's the best one to go for this one.
Dr. McRae is.
Dr. McRae, there you go. I guess Marius is going to go have dinner right now, so he's done. Okay. You talked about needing a lot of gingiva in implantology. What is an anchor pin? I think that's a really good question, because I think that sometimes we assume in implantology we know exactly, just throw that implant in there and you're good to go. But why do you need that extra gingiva, and what does the anchor pin do?
Well, shall I answer that question? Do you want to?
I'll go for it.
So an anchor pin is, it's called a pin in many cases. With many implant systems, it's really a screw that we attach to the bone, typically from the buccal. It can also be done from the palatal side, but in general we place them on the buccal side just to be able to give the guide stability. Now when we have some standing teeth, many times when we do some of these full arch cases and all the teeth are going to be extracted, we very specifically leave some of those teeth to give us the stability of the guide, or to give the guide the stability for the doctor to place the implants. But in cases where the patient's completely edentulous, you know, the gingiva has a bit of flex to it, and there's more movement of the guide. So we place these anchor pins through the side of the surgical guide, and those anchor pins go into the bone. We typically go through the buccal plate, and then we try to engage the bone on the lingual side just to give it extra stability. But we don't need that for all in cases. But I have done all-in bridges where quite a number of teeth got extracted. In those cases, we had to use the anchor pins, but not for single units. Typically for edentulous cases, if the patient is dentate but with big free end extensions, free distal extensions, in those cases, we want to place anchor pins.
Perfect.
In my case, I'm probably using anchor pins about 5% of the time.
Oh, okay. But regardless, as a dental assistant, scan the gingiva, get as much gingiva as you possibly can, I guess.
Absolutely.
That's a standard,
You never
right?
know when you are going to need those anchor pins. And just for clarification, those pins come out and then you remove the surgical guide. So that's a very temporary pin that's staying in.
Is it pretty quick process?
Yes, very quick.
Okay. Okay, good question. Here's another good question. This is actually something that we were addressing with Dr. McRae right before the webinar started. Maybe we'll just plant this little bug in his ear. Do you offer courses for assistants?
We were just talking about that, and I am going to take that upon myself. We're gonna put together an assistant course. It might be in conjunction with the doctors, and so we might do a course where I'm teaching the doctors and the two assistants are working with the assistants and doing a whole separate course in the same building. That I could see happening all at the same time. Perfect.
We'll keep everybody updated as to when that happens. And frankly, from my perspective, a lot of this could be done virtually. I'm just saying, you know, kind of from an assistant's perspective. So maybe I can sucker you guys into participating in something like that in the future, but we'll see. Okay. How often do you have to get a CBCT calibrated? It's a good question.
Well, that's a very simple answer from my side. I don't know.
I guess this is on you, Dr. McRae.
It should be done once a year.
Okay.
And most CBCTs have a calibration. It's like a tool, but it also depends on. Marius is going to be able to tell a lot of times if things aren't matching up and things aren't going right, then he'll let you know. And I'm going to, as a little side thing, and when I teach and I go around, and a lot of times Marius isn't where I'm teaching. This is what I tell people that are looking at what CBCT. That the next question should be, which CBCT should you buy?
Oh yes,
they're all good. But I am going to tell you, who should you ask? Not the salesman. Do not listen to the salesman. Don't listen to the Patterson. Don't listen to all of them. Call people that look at all the different CBCTs. Marius, your dental radiologist. Anybody that is looking at CBCTs and they have to have really good images, ask their opinion. Who has the best images that you see? That's the one to get.
I love that. The person who's actually working with those files.
Exactly.
Great.
I fully agree, and I can give an example of this. I did. We had a fairly big clinic starting to send us work, and extremely inconsistent CBCTs. And then they typically ask me, what do you do? And you know what? I just don't know. I'm not a CBCT technician. I know when a CBCT is good or bad, but I don't particularly know what needs to be done. And I suggested, well, maybe you should get it calibrated. They got that CBCT calibrated, and it was like day and night. So I think it's a good question. If this doctor, or if somebody is asking the question, how often should it be calibrated? I think you're due for a calibration. I don't think it's something we can. I don't think it's something we can do too much of. You know, when you have inconsistencies and things are not looking good, I think calibrating your CBCT is a good idea. And the same with the intraoral scanners, right? There are some on the market now that they say don't need calibration anymore, but many of them still do. Calibrate these on a regular basis to make sure that the scans are better.
Agreed. If you're seeing issues, start with calibration and move from there. But I think that's kind of a good starting place. Okay, next question. What if there is no bone? Simple question, makes sense. Where do you go from here?
Well, if there's no bone, then you have to look at, and this is what is wonderful about having a design team. We have a really good CBCT with good software. It's not nearly as good as when it goes to Marius and his team, and they put it through all of their software. Then I can actually see things even, I would say, twice as good. And then we can look at, all right, well, what about this bone? What about this bone? We can always look for the potential of bone. At that point, if there is just simply no bone, because you've got potential sinus lifts, and don't be afraid of sinus lifts. We do them all of the time. And there is very good ways of doing crestal, not lateral, crestal sinus lifts. So a lot of times we can gain bone there. If there's no bone in the mandible, are you going to be able to do major bone grafts? At that point, if you're looking to do major bone grafts, refer. I'm just going to tell you, refer.
Nice. I kind of hear another webinar coming on the sinus lifts and maybe some of your process there.
Absolutely.
I'm just saying, I'm saying it with an audience listening right now that it's harder to say no with a bunch of people watching, right, Dr. McRae?
No, I think a sinus lift course would actually be a really good course. That's
I like the idea.
It's something that it turns a lot of dentists away, even on a little sinus bump, and we do it routinely because it's now a routine thing that can be done, and you use your design team to help you with it, and we can go through those steps. You can feel very confident in your sinus lifts now.
I love this because I do think it sounds extremely complicated and it scares a lot of people away from actually addressing what could easily be done.
If I might just add, because that question is a bit difficult, but we've seen this, Dr. McRae, many times, not many times, but often enough, where the infected area around the roots, you know, by the time the root is extracted, or the roots are extracted, there is no septal bone, there is just one hole. We cannot place an implant in a case like that. Let's say that hole is all the way up to the sinus. We're not going to place the implant, and we are not going to load it, obviously. Now, there are times, Dr. McRae, that you will, depending on the volume of bone, you will say, okay, I'm going to place this implant, but I'm going to bury it. That's the one option. I'm not going to load it. And then the other option you sometimes use is I am just going to graft, and I will place the implant 3 months later. It's all about the volume of bone available at that time, right?
All the time. And we do this a lot. You have to look at it, and you have to look at every case and what is going to be the best for the patient. The patient in our office always wants the implant placed, always. But sometimes it's just not, there isn't any bone to be able to place that at the time. And so we have to clean that out. And we clean it out with a very specific system that we use. And then we place the bone. Then we come back 4 months later, traditional way, three-stage implant system. And then we go through the planning again, because now we need to know where that bone actually is. And we go through the planning stages again. We'll look at, okay, did we gain enough bone?
Nice.
But let me tell you, that's a great point, Marius. And just real quick, I had a patient come in, and he wanted, I don't know, a bunch of veneers done, and I think we did 2 or 3 implants. His case was something like close to $40,000. And we got done, and then we always interview our patients on camera. He loved his smile. But you know what? He ended up actually getting teary-eyed about one thing, and that was the tooth that was draining into a sinus for, I think he said 7 years. He had been to doctor after doctor after doctor. Excuse me. And the only thing that they would do is put him on an antibiotic. And he goes, I cannot believe how much better I feel just by removing that tooth and getting rid of the infection. I didn't know that I could feel this good. And
Wow.
It wasn't the smile. It wasn't all the money he spent. It was that he felt better. And you have to look at infection and not just look at it that this is only affecting the mouth. It is systemic. It's going everywhere in the body. And this is our job, is to, when we see it, we need to be able to remove it. And we have to remove it in a very specific way. And what's wonderful about the design process is it gives us the confidence to be able to do it routinely.
I love that. I love that you're looking at this almost like as an overall holistic health of the patient. It's not
Absolutely.
just about this aesthetic change that's going to happen. It's actually changing the way they feel. I mean, honestly, if you can chew your food, you're going to feel better. That's a fact. But if from infection that has been long term, it's a big game changer for people. And you guys are approaching this in a way that dentists are understanding how to now approach this themselves, whereas maybe they might have skimmed over it, looked over it, passed it on to somebody else. It's doable.
Exactly.
Amen.
Okay, so I got another question about the assistance courses, so we'll keep everybody updated on that. I think that that's a really neat concept moving forward, and absolutely needed. Another one, I bumped a couple of these to the very end. We have just a few more questions. I know I don't like to go over too much, but one thing I always like to mention, and a question did come into this, is Dr. McRae does a lot of courses and events, speaks all over the country. The last time, part one, we talked about when his next event was coming up. I think he just finished several of them, and I'm not sure if you have any more on the calendar right now, Dr. McRae. If you do, can we get the dates and times and where they're at? If not, we'll just keep asking you. I know it's that time of year where nobody wants to schedule because the holidays are coming. You know, people want to spend time with their families, but do you have anything?
Yes, I'm going to be in San Francisco in January, and then we are going to actually put on a live patient course, potentially with, and now we might actually add this assistant part of things in our office. And so it'll be hands-on. You'll be able to work on models hands-on, and then there'll be 2 live patients over the shoulder to be able to show how this whole process works. And it's in March.
Brilliant. Okay, so obviously you can email us, any one of us, and we'll give our, Marius and Dr. McRae will give their email addresses at the end. Do you market your courses, or do you put the details on your website at all, Dr. McRae, so people can go and look for events, or is it best just to send you an email and they can get the event dates and times, and from there know how to register?
We'll make this available to you, and then they can do it through us. They can also go through True Abutment, which is sponsoring the course.
Brilliant.
So
okay.
True Abutments is actually the one who's kind of putting it on and doing all of the signups. So
Okay.
we can probably get a link to them through your information, and I can get all that to you.
Perfect.
Let's get real. I'll get the surgical assistants, and they'll make sure that this gets done.
Okay. Okay.
Yeah.
So surgical assistants. Yeah, they are good. Okay, sounds great. So what I'm going to say is, people, if you're listening and you want to participate in a course, get your pens and pencils ready, whatever, because in just a minute, I'm going to have Dr. McRae give you his email address. If you don't mind, Dr. McRae, Marius, you can give your email address so people know how to sign up for the portal if they want to get started, because that's my next question. How do I start? And I guess that's kind of through Marius, I guess, you know, how do they send their first case to you? Would it be through your portal? They contact you first? How does that look?
Yeah, the easiest way to do it is to go to allinplanningcenter.com, and then at the top click on submit a case. That takes you to the portal. You sign up on the portal, and you know what, at the end of the day, you can just give me a call, or you can just send me an email, and I can guide you through the process. But the first thing you need to do is get on the portal, and that is at allinplanningcenter.com. At the top menu, click on submit a case. That takes you to the portal so you can sign up, and then from there we communicate via email.
Okay, and I promise next time we will have the email addresses and websites here. I will see to it so you guys can reach out a little bit easier. Again, get ready to take their email addresses down so you can ask questions if you would like to. But before that being said, I thought this was really important. Prior, we discussed this with Dr. McRae, but question came through. I don't have a printer in office. I know part of implant planning, a big part of that nowadays is people getting their printer in office. Marius can do, and his team works their magic. They send the files to the doctor's clinic directly. They can print what they need to there. This person doesn't have a printer, and I'm glad it came up because it would have fallen off my radar. Dr. McRae, do you have a solution for people right now who do not have a printer in clinic that can maybe help them get started? I know that labs have it constantly, but also it's nice to have a point of contact. Yeah.
Yes, and so we actually have an in-house lab that can do that work for them. Austin, actually, he's my son, and he does all of our work, and he is, I'm amazed at how accurate everything is turning out. I would say that, I don't know, of the thousands of cases that we've done, I might have had to touch my surgical guides 3 or 4 times, and literally just have to remove a little piece to be able to get it to seat, because it almost is always just, I'm amazed at how good they are. So the it's called All-In-Implant Lab, I think is I should know that, but I can also give you that information if they want information for that. The easiest way is to ask by sending us an email through info@mcraedental.com. That's the easiest one. That
Perfect.
will go to the surgical assistants, and they can then set that up. He's very reasonable on the cost of his the surgical guides, and so yes, they can get that to him very easily.
So what would actually happen is they would submit the case on Marius's portal.
Yep.
And then from there, after they went through the planning, like you just did, kind of demonstrated with Marius, they would request that he send those files to Austin's printer, basically. And from there, Austin would print, ship out to the dentist, and go from there. Okay, simple process. Same, basically the same thing. The way it would be with the lab.
Yeah, so they would get all that they would be requesting. So they get all the surgical guides, because there's many different surgical guides that we can utilize. So they would receive all the surgical guides, the custom healing abutment. They would receive their final abutment and PMMA if needed. So all of that could be then shipped directly to them, overnighted, and they could have it the next day.
Brilliant. It's a good solution for those who want to kind of, number one, dip a toe into the process here, but maybe you want to go full bore, but you also don't want to buy a printer and have to worry about doing that work yourself. So either way, you know you're getting quality, and you're able to move forward with the process.
Do it that way first, have others do the work, get to where you get really good at it, and then eventually look at purchasing it yourself. Yeah, absolutely. I think that's the future for all offices, is they will have a printer in their office, but don't buy one until you start doing a bunch. And what is a bunch? I would say more, if you're doing 4 to 5 a month, time to be thinking about getting a printer. Wouldn't you say, Marius?
Yeah, I would say, there's, apart from the cost saving, if you do it yourself, the biggest hassle, and we added today, FedEx said they will deliver at 10 o'clock this morning. Patient is scheduled for 8 o'clock tomorrow morning. Sorry, FedEx made a mistake. Well, they just changed the date on the tracking. No, it's only going to be there tomorrow afternoon. Patient needs to be rescheduled. Even though we gave the lab enough time, these things happen. They just happen. Sometimes a delivery never arrives. It left the lab, but it never got to the clinic. So for those reasons, I would say as soon as you can, print your own guide. I do not suggest you mill your own crowns and custom healing abutments. I say leave that to the lab guys. But a 3D printer, I would say if you do, I would say 5 cases plus a month, then it's going to make sense, because there's more things you can do with the printer than just the surgical guides.
Nice. Okay, we've gone over as always, but before we wrap up here, Marius, can I have you just say your email address, sharpen your pencils, everybody, and then I'll have Dr. McRae do the same once again. I'm never fast enough to have my pen out ready when I need to write something down. We'll give everybody a second chance here. Marius, what is the email address if they want to reach out, or your website, wherever to go in order to get started?
I would say the easiest is go to allinplanningcenter.com. All the details are there. All the information is there. My contact number is there. So that would be the easiest one.
Perfect. And Dr. McRae, get a hold of you, whether it's for Austin or, I know you're checking your email address right now.
No, I'm not. It's info@mcraedental.com.
Perfect. Okay. Well, that being said, we'll go ahead and wrap this up. Again, part 2 of our series. We've got one more part coming up before the end of the year. We'll get everybody the registration link very quickly, a few days, maybe a week from now. Please reach out with any questions. We'll make sure we have better contact information at the end of our next webinar, but just grateful everybody can join. I know how busy both of you guys are, Marius and Dr. McRae. I know that this is the end of the day of a very long day of treatment and planning for you, so we're super grateful. And we look forward to seeing you next time. So thanks again.
Thank you.
Yeah, thank you.
Okay,
Have a
thanks
good
for
night.
joining, everybody. We'll see you next time. Bye-bye.
Thank you. Bye.